Hi guys, and welcome to today's full drug summary on methotrexate. So, let's get straight into it. What is methotrexate used for? First of all, it's used in rheumatoid arthritis as a DMARD, in severe psoriasis that does not respond to other therapies, and in chemotherapy for cancer such as leukemia, lymphoma, and some solid tumours. Now, how does it work? First of all, I'm going to tell you that it interacts with the folic acid pathway. So what pathway is that? First of all, when we take in folic acid from our diet via broccoli, cereals, green leafy vegetables, via the enzyme DHFR or dihydrofolate reductase, that makes tetrahydrofolate. And this is involved in DNA and protein synthesis. Now, when we put methotrexate into the mix, it inhibits DHFR, which therefore prevents dietary folic acid from being made into tetrahydrofolate, which, as you can see via the chart, the little flow diagram, can prevent DNA and protein synthesis via preventing cellular replication. Now here it is on the right, exactly what I've just said, the first two bullet points. The third bullet point, very important, this is useful for chemotherapy because methotrexate, or rather rapidly dividing cells, are very sensitive to methotrexate. Hence this mechanism is very useful. As we also know, methotrexate is anti-inflammatory and immunosuppressive, but the effects are not that well known. They could involve adenosine receptors being stimulated and perhaps involving interleukin 6 and 8 and TNF alpha for the required effect. Anyhow, this dietary folic acid pathway and how methotrexate interacts with it is very important. In terms of side effects, here's some big side effects here on the screen, and it starts with hematological toxicity, where you can get low white blood cells, in particular neutropenia is what we would look out for, where we could have an increased risk of infections, mouth ulcers, sore throat and pyrexia, low red blood cells with anemia, which can manifest as fatigue and pale skin, low platelets, i.e. thrombocytopenia, where you could have unexplained bleeding and bruising. So hematological toxicity is a big side effect, very well known with methotrexate. It should definitely be reported and medical attention sought if you have any of those symptoms mentioned. Now, with the other three, gastrointestinal, pulmonary and hepatotoxic, you would also seek medical attention. And I'll just briefly cover those side effects too. So in gastrointestinal toxicity, if you have stomatitis, such as an inflamed or sore mouth with or without ulceration, or if diarrhea develops, withdraw the drug, seek medical attention. Pulmonary toxicity, again, seek medical attention if you have dyspnea, shortness of breath rather, cough or fever, and discontinue if pneumonitis is suspected. And hepatotoxicity, because liver cirrhosis has been reported. So if you have any symptoms of hepatotoxicity such as abdominal pain or discomfort, jaundice, pale stools, dark urine and nausea or vomiting, seek medical attention. Now there's a lot of side effects there. Make sure you tell the patients the main side effects to look out for and that they have to seek medical attention, but they will get a leaflet with this. Make sure they read it to get a better all-round understanding of their medication, methotrexate. Now, for important BNF safety information, methotrexate is taken once a week in autoimmune conditions, perhaps less commonly in some chemotherapy regimens, but the standard is once a week. There's an increased risk of overdose if they take the medication daily or more often than once a week, and serious side effects can include seizures, coma, and even death has been reported. Therefore, carefully advise on the dose and the frequency. Now, to help in reducing the risk of any overdose, only one strength of methotrexate is usually prescribed and dispensed, and that's the 2.5 milligram tablets. Now, the prescription label should clearly show the dose and frequency too, and the patient should be warned to report the onset of any blood disorders, liver toxicity and respiratory effects. Now, gastrointestinal toxicity isn't mentioned here for some reason, the BNF doesn't mention it, but I would add that onto the list too. Now, prescribers are also advised when prescribing to make sure that patients can understand and comply with the once weekly dosing, to consider the patient's overall polypharmacy burden, to inform the patients and carers of the potentially fatal risk of accidental overdose, and to advise patients and carers to seek immediate medical attention if overdose is suspected. Next, additional information for the patient, advised to avoid self-medication with any NSAIDs, particularly over-the-counter NSAIDs, which can reduce the excretion of methotrexate via vasoconstriction of the afferent arteriole of the nephrons in the kidneys, which can cause toxicity, unless of course it is well known and agreed upon by their specialist and he or she may even prescribe an NSAID for them to take at the same time. In which case, cancel an NSAIDs well. When I said take at the same time, I don't mean take at the same time exactly as methotrexate, but I mean, for example, a PRN ibuprofen to take when they have pain, for example. Now, advise that contraception during treatment and for 6 months afterwards is very important for both men and women, as this is a teratogenic medication that can cause fetal malformations. Pregnant women, as a result, are also advised to avoid handling it completely because it is cytotoxic and can be absorbed through the skin just by touching it. And if they've had a baby and they've been started on methotrexate, again, do not breastfeed whilst on it because methotrexate can be present in the milk. Now, we've just seen the folic acid pathway, so make note that folic acid can be given to reduce the side effects of methotrexate. Now, it can be given as 1 mg once a day, or the more common regimen of 5 mg once weekly, but neither are to be taken on the same day as methotrexate because, that can actually reduce the efficacy of methotrexate, as we've seen in that pathway. You wouldn't get the inhibition of DHFR, tetrahydrofolate, and therefore DNA and protein synthesis as you'd like, not to the same extent if the folic acid is obviously given on the same day. So avoid same-day administration of folic acid. Now, avoid live vaccines, because obviously with methotrexate you may have a lower immune system, so you may be at risk of actually developing the illness from the vaccine, in which case there are other vaccines available, inactivated vaccines, that you still should get. And encourage patients just to write the day of the week that they take the methotrexate on the alert card, and encourage them to carry it with them. Now, in addition, some extra information for yourselves rather than for the patient. In severe hepato or renal toxicity, methotrexate is generally avoided. If the renal toxicity isn't too bad, we may consider reducing the dose. Either way, even in hepatotoxicity, would consult local protocols, just because, as we've mentioned, liver cirrhosis is a risk. Now, we've mentioned toxicity a few times now. In terms of how to treat it, either if it's suspected or if it's as rescue therapy, we would use folinic acid, and this is given as calcium folinate. Now, in terms of contraindications, I thought I'd mention this one. It's quite important because if a patient does have an infection, for example, they've been admitted to hospital, it's a patient with pneumonia, their immune system may be trying to mount a defense against this infection, but the methotrexate will obviously be suppressing that immune system, and therefore it may be in some cases worth, after a discussion with a prescriber, holding the methotrexate and not using it for a week, just to see if, or rather, just to reduce that immunosuppressive effect so the immune system can fight back against the infection. Now, monitoring is nice and easy with methotrexate. You do 3 things: full blood count, renal function, and liver function tests every 1 or 2 weeks until therapy is stabilised. Once stabilised, you monitor every 2 or 3 months, and that's it. Obviously, if you've just had your bloods done a week ago and you've been stable and your next blood tests are due in 3 months, and you get some of the side effects I mentioned earlier, you get a sore throat, you get mouth ulcers, you get a fever, you should report to a prescriber immediately, seek medical attention to get blood tests done, just in case you may have a sudden lowering of your immune system. You may have bone marrow suppression, i.e. blood dyscrasias. Now, as mentioned, if there's an overdose, folinic acid can be used. And just regarding the monitoring, even low-dose methotrexate has shown fatalities relating to blood dyscrasias and liver toxicity, so it's definitely worth having this monitoring done. Now, in terms of interactions, the big one on this screen is trimethoprim as a folate antagonist, or cotrimoxazole, which contains trimethoprim. With this, and this is a very serious interaction, you would not use this with methotrexate under any circumstances. You get very serious systemic toxicity and pancytopenia, so all 3 types of blood cells, white, red, and platelets are low. Oral mucositis, nephrotoxicity, fatalities basically have been reported with this medication. We've mentioned NSAIDs already in how they vasoconstrict the afferent renal arteriole and can therefore reduce the excretion of methotrexate, and thereby it's in the body for a longer period of time. Penicillins likewise are predicted to increase the risk of toxicity when given with methotrexate. The manufacturer advises monitor. With NSAIDs as well, I beg your pardon, we would monitor. As for PPIs, which is an interesting one, they too can reduce the excretion of methotrexate and therefore increase its concentration in the body, or rather how long it's in the body, compared to if it were to be excreted out normally. And the manufacturer suggests either use with caution or avoid completely. Now, other drugs which may interact are those which cause blood dyscrasias or hepatotoxicity, so other immunosuppressants, for example azathioprine, leflunomide, or hepatotoxic drugs, for example rifampicin or doxycycline, for example. Just to be aware that there are risks with using all sorts of different drugs with methotrexate, and as long as we avoid the big ones such as trimethoprim, many other drugs can be used as long as we monitor very carefully. Now, we have covered what methotrexate is and what it's used for, how it works, the side effects, the big side effects rather, important BNF safety information, and I can't stress enough how important it is that the patient knows that it's to be taken once a week. All the additional information and how the patient should be careful with OTC, over-the-counter use of medicines, and more about treating methotrexate toxicity with folinic acid, contraindications, particularly active infection, and we've just covered some interactions, in particular the big one, trimethoprim. So hopefully that video was helpful for you guys. That was a whistle-stop tour of methotrexate. So get your pens and paper and get studying. Enjoy.